right, good morning. A new talk for me, so I enjoyed putting this together. Quick, I say I don't have any disclosures, and part of that's because I'm an editor of a journal that Dave's mentioned, so we're not allowed to attend industry events or ad boards, so sorry I had to miss that. But the good news is we have this nice new journal to add that's an academically focused one of all aspects of urology. So now there's 4 publications from the AUA, including AUA News, and we do use cascading to move articles around to get the best fit for them. Ours, of course, is known for being fully open access. And we've had some papers from this meeting actually published and under consideration as well. So integrative care is kind of an interesting topic. There's some parallel terms you can throw out there, such as coordinative care, comprehensive, seamless. What you're trying to get around is fragmented care. It's team-based over siloed is one way to describe it. Actually, I threw in a ChatGTP definition. It reminded me we've talked a lot about robots and AI. There's 2 interesting things about AI in publications. One we had to do for AUA publications last year was get out an author instruction that you can't use ChatGTP as an author because they can't take responsibility for anything. The next round of controversy we're dealing with now is that you can't put copyrighted material in the robot without permission and then write a paper about it. So you'll see it's kind of similar to the New York Times suing ChatGPT over people uploading whole articles that are copyrighted. But you can use those like as a template for a talk just to kind of outline it and get it going. So that's actually what ChatGPT defines as integrative care, and that's actually some of the outline aspects of it in terms of the multi-specialty care, siloed care communication pathways, and allied health care. Now, Dave talked on Sunday night a bit about sort of the prostate 360 model, sort of the who, what, where. Actually, he didn't put where. Where is actually kind of the interesting part that I found putting this talk together. In theory, integrative care would be in multidisciplinary clinics at the point of care. It could be in the hospital with rounding, coordination of care, multi-teams. In reality, though, that's hard to pull off. I think we all realize that. So I'm going to kind of emphasize other areas where it really practically happens. It includes guidelines panels, because those are multidisciplinary. You're actually doing it right now. Just being at a CME meeting and listening to doing specialties and taking that knowledge back to your patients, that actually is integrative care as it formulates, what you learn, how you improve your care. And there are kind of different types of CMEs. This one's kind of a balanced type of meeting, but we've all had the experience of like at a surgical meeting where we always bring in a token radiation oncologist to mix it up, and vice versa. I've been the token surgeon at a radiation oncology meeting, so that always helps. Consulting panels, I think, I actually add to the mix where you let people get in a closed room and kind of fight it out, and some of that dictates how protocols get written, new trials are conceived, et.cetera. We'll talk a little bit about tumor boards. Clinical trials and protocols I would put on the list because, if you look at the list on that bullet point, at least at MD Anderson, to get a protocol through, it gets 3 medical reviewers, including people from other specialties, pharmacy, path, imaging. There's all tricks within the EMR you can use to put together multidisciplinary care. And again, the peer review process actually can count because we actually learn quite a bit by having multidisciplinary partners in peer review when it's called upon, and that kind of formulates how we edit and what we finally greenlight for publication. When I was a fellow, this was kind of the model of integrative care at the tumor board. We could only really present a handful of cases because if we had a protocol, then you put them on the protocol, you don't present them, and it can't be a boring case. So it really came down to 3 categories, like people who had 2 cancers to coordinate. Look what they messed up on the outside was a common topic. And then the sort of the extreme indications, I dare you to operate on this guy was a common one. Now, it's really expanded in the 22 years since I finished fellowship. It really becomes a cross-trainer among specialties where they can ask surgeons, like, what are the true indications for surgery or not, and vice versa for med-onc and rad-onc. Of course, you get verified path and imaging review. There are different formats. If you ever travel to Europe and go to a multi-conference, they actually try to go through the entire list of what they're treating that week, like 2 minutes a case. So just to keep everybody honest almost seems to be the purpose. We tend to be selective. It has to be more interesting for that, but it does become the basis of how we prioritize what protocols need to be added, for sort of continuing knowledge gaps out there. And of course, it does. Sometimes we identify a super specialist to handle a particularly difficult problem. And again, I think it's really meant to reduce specialty bias so we all keep each other honest. So this is an example of a different talk slide where when people ask me who can have surgery or not, this is my slide of where we look at that about challenges to get to the prostate, access, space around the gland, that kind of thing. So this is really to help educate the other disciplines about what we can and what we can't do. Now, we do have multidisciplinary clinics in localized, and we have variants of that in advanced. Do we actually go to the room together? Well, we have, but eventually you kind of learn each other's feel, and you kind of so we mostly meet in the physician workroom. Be sure we agree on optimized diagnostics, treatment options, clinical trials. That's actually a MD Anderson marketing picture from like 14 years ago where they made me write with my left hand for some reason, made the picture look right. One of our radoncs, Chad Tang, actually wrote up our multi-clinic if you want to really go into treatment choices of how people enter for that. And lots of people have sort of diagrammed both multidisciplinary clinics and tumor boards, the various specialties that work around that. This is one from urology practice on integration in advanced prostate cancer clinics, et cetera. Now, again, I think the guidelines panel is one I want to emphasize because, as articles are written, you've got original articles, they became narrative reviews, they can sometimes become systematic reviews. Then panel discussions can lead to guidelines, both sort of narrative and, like a full association, AUA, EUA type of guidelines. If you look at kind of the life cycle, this is how like an AUA guidelines get put together. You have a multidisciplinary panel that sets the questions. You have professional evidence reviewers that write up the evidence behind the questions. Then the panelists write the guidance statements. And actually even post guidelines, there's an external peer review system. So like the 22 AUA guidelines, we made several meaningful edits just based on the external review as people pointed out different literature perspectives. And then of course the board greenlights it and it goes into publication. So I think that's actually, because we quote guidelines all the time as a starting point for how we approach the patients. A quick highlight, I believe it or not, social media can be a tool. It's got its pro and cons. So I've posted a couple just direct crowdsourcing questions. We had a patient get a Barrigel placed and then want surgery. Can you do that? I don't know. I've never done it. You post the question. I got like 10 responses saying, yeah, it's fine. Go ahead. On the other hand, I had an APR, radiation, colostomy. Can you do a prostatectomy on that 10 years later? A lot of equivocation. So I actually decided not to do that one. There was an interesting article on focal therapy from a big cancer center, and a well-known radiation oncologist, basically took it to task for methodology issues, which is fine. That's totally legal, but that is the downside of social media, where it kind of devolved into literally personal attacks against the urologic author, the radiation guy actually defending the urologist, other radiation oncologists making fun of it. So that's kind of the dark side. But crowdsourcing can be a way of communicating, ideas where people kind of get stuck and need help. I threw this slide in there, the role of geriatrics, and one of the reasons to remind me to say is a lot of integrative care is what I would call the complementary versus maybe the competitive. So on that previous slide, there are the competitive points of care where you're going to do this therapy on a list. That means you're not doing these other therapies. And yeah, so the integrative care is a way to keep all that honest. But there's a lot of topics in here where there's no controversy here. Yeah, if you have elderly patients, geriatric care, the whole previous talk on metabolic syndrome, no controversy there. Get all the help you can get. There's whole articles on triggers for palliative care, pain control, hospice, et cetera, all relevant, of course. So a quick scoping review, I would say that one message to authors back to peer review is be sure you optimize your keyword search. Actually, if you keyword search this talk title, you only get about 200 hits. And I think it's probably because people forget to add integrative care specific to prostate cancer. And even of those 200 hits, you only end up with about 30 articles that are kind of on point. But quickly, because I'm almost done here, yes, you should treat obesity. There's whole issues on multidisciplinary clinics in biochemical recurrent disease, genetic screening, especially in advanced disease. Prehabilitation, we've heard themes on that. You can do that before surgery. You can also do that before starting ADT. We had talks on that Sunday night. patient preferences on sort of the quantity versus quality of life, sort of post-marketing. That's a 10-year-old article in Abiraterone that was just useful on how to use a drug properly once it's out of its clinical trial environment and in real-world use. Again, the role of geriatricians, the role of multidisciplinary care, even whole articles on how to get patients to exercise despite bone metastasis and how to do that safely. So in conclusion, I think the practical aware of integrative care happens in a number of places that I've noted. In the bottom line is good news, you're doing it right now. And then a number of future directions of trying to improve that and fix barriers to get integrative care at the point of clinical care. So thank you.